Good afternoon. Welcome to this afternoon's presentation. My name is Jennifer Hannon, and I am the moderator, and I am a representative of Office of Behavioral Health. Today's session is called Treatment to Adolescents with Anxiety Relating to COVID. Our presenter is Donna Wimberly, MSW LCSW. Thank you for attending our 2020 Behavioral Health Symposium. We're happy to host this event as a virtual conference because we care about your health and safety, but we also understand how important it is to provide relevant and robust continuing education to Louisiana healthcare professionals. For quality purposes, all participants will be muted during the presentation. If you would like to submit a question to the speaker, please use the chat box in the virtual platform. This session is accredited for 1.25 hours for the following professionals: social workers for clinical credit, peer support specialists, psychologists, nursing contact hours, AMA, PRA Category 1 credit, and LPCs. Full participation is required to receive credit and will be monitored throughout the session. You will receive an email from Women's Foundation with detailed instructions on how to claim your credits and to access your certificates. Additional information is available in the digital event booklet. Financial disclosures. Donna Wimberly has no financial disclosures. None of the members of the Symposium's Planning Committee or any session moderators have any financial disclosures. Donna Wimberly is our speaker this afternoon, and she's a licensed clinical social worker with 15 years of postgraduate social work experience in clinical and managerial roles across a variety of settings, including corrections, hospice, dialysis, inpatient and outpatient mental health, and private practice. Donna earned a Bachelor of Arts in Psychology and a Master of Social Work from Louisiana State University. Donna provides therapy to children and teens in her private practice, where she is passionate about assisting her clients in successfully navigating challenging experiences. Donna is a member of the National Association of Social Workers and has served as a member of the NASW Louisiana Board, the regional chair for the local chapter, and as a past and current committee member for multiple NASW Louisiana committees. Donna has vast experience in authoring and presenting continuing education programs throughout the Donna Wimberly state of Louisiana. Please join us in virtually welcoming Donna Wimberly to today's presentation. Thank you.
Hi, I guess y'all didn't know there was a Donna Wimberly state of Louisiana, but welcome to it. I don't know if you're going to be excited to be in the Donna Wimberly state of Louisiana, but I'm happy that you're here. I want to say thank y'all for letting me be here, and thanks to all of you for allowing me to be with you. I know this is a crazy time. Things are a little different to be virtual, but I'm excited to be with all of you today. So we have a lot of information to go through, and I'm going to hop right in and get started with that. I do have a tendency to put a lot of information into my presentation, so you have those to use moving forward. We're not going to go through all of them in detail because we just don't have enough time, but I did put a lot in there so you'll have it for use in your practice as well. So we'll go ahead and get started. All right, so while we're not in person, we are still here together. I want us to be able to use the chat as much as possible. So if you do have questions, comments, anything, please jump in the chat and then they'll be moderating that. I think it's really important for us to appreciate all of the value that is within this group. Although we're not here in person, we have a tremendous amount of experience, and I want us to be able to benefit from all of you as well today. So we are the sum total of our experiences. So some of this information is information I've talked about before, but it's different today because of the people that are in this group with us. So I want us to really please use the chat. Don't hesitate to wait till the end to ask questions. Please jump in as we go along. We know that our experience and our uniqueness can be the key that unlocks the success for our clients. So information that you may have had before, address those clients. We're in a different place today. So let's really utilize, our world has changed. Even in the last week, our world has changed. So we really need to take today and put this towards our clients that we have, not only today, but in the future. So of course, we're going to talk about adolescence and anxiety. So first of all, what is adolescence? It's the onset of physiological normal puberty that ends when an adult identity and behavior are accepted. Who says that? So do you think that an adolescent clearly understands what that means? Absolutely not. So it is a period of development that corresponds roughly to ages 10 to 19. So that's kind of what we're looking at today. There's a little gray area depending on developmental stages for each child. So it is gray, but we'll look at 10 to 19-year-olds for the most part today. It is also a time where there is a higher level of thinking. And that's where we kind of get into some iffy spots with these adolescents. And we'll look at that as we go. But of course, they start to test their own hypotheses. They want to know what might be true. They want to see if there's this infinite amount of possibilities out there in the world. And of course, they want to search for their identity and their independence. And that comes across in so many different ways as they socialize and also in their families. It is, of course, a time of developing socially and emotionally. And of course, it's a unique and formative time. Now, anxiety, this is not earth-shaking information, but we'll talk about what it is. Of course, it's the normal reaction to stress. It helps someone to deal with their tense situations. It helps them to increase their motivation, helps them to cope, and is also known as the great masquerader. So when we say all of this, it sounds like anxiety is fantastic. And I don't know why we're spending so much time today talking about what to do about it. It sounds great. Who couldn't stand a little increase in motivation, a little extra coping? It sounds fantastic. But the problem comes when there is an excessive, irrational dread of everyday situations, when the presence leads to significant impairments in their quality of life. This often is stemming from their behavioral avoidance. They may have limited developmental tasks. They may avoid interactions. We're seeing so much of this today in today's society with all of COVID especially, but in so many ways. So this is something that anxiety is good. Too much of it is where we come into the problem. Of course, anxiety, we have the disruptive or antisocial behavior that can kind of mask that anxiety that children have. Adolescents with anxiety disorders, of course, are more likely to use drugs and alcohol. They want to kind of wipe away those anxious feelings, and that's an easy way for them to access that and readily available, wipe out the anxiety, and they feel better short term. Of course, it's important for us to identify and treat these symptoms of anxiety very early on. The earlier, the better, and we're going to look at some stats on that later. Okay, types of anxiety. 5 different ones we're going to look at. The main ones, of course, separation anxiety, phobias, social anxiety, general anxiety, and panic disorder. We'll look at kind of how to screen these as we go. But first, anxiety disorders are often called internalizing disorders because the symptoms primarily involve thoughts and feelings. That's where the symptoms start. We may see something very different. So the different types of anxiety, of course, these are things that you've heard of before. We'll just briefly go over them. Of course, separation anxiety is the fear of being parted from people that they're attached to. They worry that something might happen to their attachment figure while they're away. This can be at any age. We often hear of this as infants or toddlers having separation anxiety. This is a very real thing for our age range of adolescents. So it's really important for us to not sweep this one under the rug and say, oh, that's just for babies. It's not. Also, phobias. There's an intense fear or an aversion to a specific object or situation. Also, social anxiety, which is a general intense fear or anxiety towards social performance situations. Also, general anxiety, where they display excessive anxiety or worry most days for at least 6 months about a number of different things. This could be their personal health, their work, their social interactions, their everyday routine life. It could be going to school. It could be going to a friend's house. It could be anything, but it's a general anxiety over a number of different things for at least 6 months, which is really important. Also panic disorder. Of course, it's the recurrent, unexpected panic attacks. Then we start to have anxiety about if we're going to have a panic attack. So there's a whole lot that goes into just these 5 categories here. What are the symptoms of anxiety? Now, these symptoms can come from either triggered by real or imagined threats. Remember, these children are starting, and I say children, I know I use that term lightly, but we're using that as we kind of move forward. And these children are starting to have that higher level of thinking. That's where a lot of these imagined threats come in. They're starting to learn more about the world. And is this a real thing? Is it not? Should I be afraid of it? I saw it on TV. Someone at school told me about it. There's all different things. Their imaginations are still running wild as they adjust into this adolescent phase. So we start to see a lot of symptoms. Of course, inability to relax, anger, fatigue, dread, tense muscles, headaches, dizziness, stomach aches, nausea. Those are huge, huge symptoms that we cannot overlook. Fight, flight, or freeze reactions, sweating, rapid breathing, and the list goes on. The last one there is pillow heart. That's something that we use in our own house, but it came from me asking how one of my children was feeling, and they said, I feel like my heart has just turned into a pillow. And so instantly I'm like, oh no, this is not good. What's wrong with your heart? And as we talked about it, it was really anxiety, and they didn't have the understanding that that was the feeling. But you know the feeling when your heart's fluttering and it feels like it's squishy? That was what she was describing. So we refer to that as a pillow heart at our house. So something for us to really think about how they feel, and then of course developmentally how they can express it. Okay, so separation anxiety, we see stomach aches, headaches, and dizziness with this as well. Extended absences from school because mom and dad are tired of fighting the battle of no, you have to go to school, no, you have to go to school. There's also a genetic predisposition to separation anxiety. So if we're seeing that there's a family history, we may notice it more. It's something for us to look out for. This separation anxiety, as a note, it does have to last at least 4 weeks, and it has to have an inability for them to function at school and with their friends. So we don't just say they didn't want to go to dad's house or to grandma's house, or they didn't want to spend the night somewhere. This is for 4 weeks where they cannot function both at school and with their friends. Okay, social anxiety. This is something I'm sure you can think of many adults who have social anxiety, and oftentimes it started as a child and they didn't learn how to handle it and how to adjust and cope with it as well as possible. So we see it a lot in adults as well. Of course, usually around the age 8 to 15, we start to see some things kind of pop up, but it may be undetected by other people for a long time. I can think of clients that have had in the past that it wasn't detected until they were almost in college. So they function all the way until college, and then you can imagine they didn't function in the most healthy ways when they learned to kind of try to treat their own anxiety then. So it's good for us to really jump in and address these things early on. Another key point here is girls with high levels of social anxiety have been rated by their parents as having poor social skills. So especially, of course, in assertive and responsible social behavior. A lot of times you'll hear mamas of girls talking about they don't have friends, or their friends don't invite them to do things, or they're not included at school. There may be some anxiety that's there. It may not be because no one wants to be friends with her. There's probably something else going on. Selective mutism. This is something that parents get so frustrated with, or parents may not even know about it, and other people are frustrated by it. This is anxiety disorder when children are unable to speak. It is in some settings and to some people. So some parents will say that's so rude, that's disrespectful, you have to speak, and we go on, and we're just increasing their anxiety by telling them they must speak. They have an inability to speak at that time and that setting to that person. This also can have a genetic factor. It cannot be diagnosed, in the first month of school. How many kids are not sure of what's going on, especially as school starts back in some areas and is about to start back in others? It is different this school year than ever before, and they are going to have some anxiety. So if a child is not choosing to participate in classroom discussions during the first month of school, it's hardly selective mutism that we can pick out at that point. Should it go on beyond that transition period, which again could be extended this year? So if it goes beyond that, then we start to say, okay, maybe there's an issue here. I think it's important, though, for this school year in particular, if they're starting out virtually, they may not want to participate there either. But as they transition into in-person, I would be really reluctant to use a selective mutism diagnosis for a child who has just transitioned into school, whether that's, in-person school starts in January or who knows when. We don't want to label them with that first month during their transition, regardless of the time frame. So another important thing is that anxiety makes us not only overestimate our risk, but it also causes us to underestimate our ability to cope with those. So that's a really important thing Dr. Jennifer Blossom stated, and it is so important. It has those two different factors there, and we have to make sure we're paying attention to those. Okay, so I know we're virtual, and I know that many of us are busy, and you're probably multitasking. I get it. But I want you to pay attention for just a minute. It's hard to not be distracted, I'm sure, by other things going on in the room, but we have to remember that this time is really set aside for the children that we are going to be working with for the next several months as we go through COVID, but in our practice in general. So if you're multitasking, I get it, but let's pay attention here and come back to me and listen to some of these facts. I think they're huge, they're eye-opening, and it really does kind of help you to see that this is something that is very prevalent, not only in your practice, but in school and community settings, and it's something for us to kind of pick apart. So 7.1% of children ages 3 to 17, so there's a bigger age range here, but there's 4.4 million children that have been diagnosed with anxiety. That is just the ones who have been diagnosed. Think about how many other children, maybe in your own family, who have had anxiety and has never been diagnosed. So we're talking about 4.4 million who have just been diagnosed. That's a lot of children. So more than 1 in 3 of age 3 to 17 with anxiety also have behavior problems, and 1 in 3 also have depression. That's a lot, and that just blows my mind every time I read it. Of course, there's an estimated 31.9% of adolescents, again, this is 13 to 18 age range, that had anxiety disorder, according to the National Comorbidity Survey. We also have 80% of kids with diagnosable anxiety disorders that are not getting treatment. 80% of children that are able to be diagnosed, truly diagnosed, not just struggling to adjust, truly diagnosable anxiety disorders that are not being treated in any way. We're not talking about just medication, just therapy. We're talking about any type of treatment. They're not being treated at all. And of course, we know early treatment can prevent future difficulties, loss of friendships, failure to reach social and academic potentials, feelings of low self-esteem, and the list goes on. So anxiety is the 9th leading cause for adolescents aged 15 to 19 years of age, and 6th for ages 10 to 14. Anxiety disorders are the most common mental illness in the United States. This was all data from before the world as it is today. So imagine how those numbers have jumped tremendously. And of course, people with an anxiety disorder are 3 to 5 times more likely to go to the doctor and 6 times more likely to be hospitalized for psychiatric disorders than those who do not suffer from anxiety disorders. So if we can handle some of this now, it's not saying they'll never be anxious again, but if we can handle things as children, you can help them to be able to function at a higher level as adults and hopefully to eliminate some of those excessive hospitalizations. Children with anxiety disorders are more likely to have a whole lot of things. These are just some of them. Of course, school problems, low self-esteem, increased risk of depression, suicide, and substance abuse. That's a huge one that we need to pay attention to. Of course, school problems and behavior issues that are sometimes lumped as a different issue, which really may be anxiety. But when you just look at their self-esteem, their future with depression, suicide, and substance abuse, it's hard for us to be able to not focus on the importance of treating anxiety. Okay, so as far as diagnosing children with anxiety, of children with anxiety, 11.9% also have ADHD and 9.4% have ODD, 2.7% with a tic disorder. So we sometimes have a tendency to focus just on one piece of the puzzle, and we see that the tic disorder is something that we want to fix, so we focus on that without addressing the fact that there's more going on. Children with behavioral dysregulation as a result of anxiety may be diagnosed with ODD. So we see an inflation in those numbers when, again, a lot of it is anxiety. Majority of adolescents with substance abuse disorders have comorbid psychiatric diagnoses, especially anxiety. Of course, anxiety disorders pose greater risk for developing eating disorders. We sometimes forget about those in really young adolescents. We don't notice it until they're older. And then trichotillomania also goes with this. This is something that you think you only hear about in your textbook in graduate school, maybe. But it's a real condition that you see more. I've seen more in my practice than I ever thought I would. I can remember learning about it and thinking, where do you ever see that? I had never. I see it quite often, or have seen it quite often. Okay, so facts. Anxiety is the third most commonly diagnosed mental disorder in children 3 to 17. What else is in there? ADHD comes in, of course, at number 1. Number 2, behavior disorders, and then followed by number 4 as depression. When we look over the time frame, of course, these studies were done back in 2003 all the way to 2011 and 12. I would like for somebody to show us the numbers when we start to look back at 2020 and see where these numbers are. But the anxiety and depression have increased among the ages of 6 to 17-year-olds. So in the blue, you have those who have ever been diagnosed with anxiety or depression. Orange is those diagnosed with depression. And then is it coming up as kind of a gray for y'all? It's the ones who have ever been diagnosed with anxiety. So when you look from 2003 at 5.4 all the way to 2011 and 12, when we just look at those who have ever been diagnosed with anxiety, we're already above that at 6.4. Okay, treatment rates. We talked about how we're only looking at the number of children who have been diagnosed. When you think about diagnosed and treated, we know there's a big difference in the numbers there. But when you look at these children 3 to 17, you have depression, anxiety, and behavior disorders. If we're looking depression, there's a lot more children that are being treated for that than not being treated. But with anxiety, we're almost half and half. A little bit more with behavior disorders. But anxiety, it seems that we sweep some of that under the rug. And I really want to challenge you to take away from today to implement this in your practice and say, what are we looking at if we're in the school setting? What else could be going on? Could there be anxiety instead of just a true behavior issue? Maybe it's coming across that way. Or maybe we're looking at depression and it's really anxiety and they just don't have the ability to say that. So a few more statistics before we move on. 60% of all individuals with anxiety disorder seek help with a mean delay of 8 years. So when we're looking at adolescents, if there's a mean delay of 8 years, they're already in college, which is kind of the situation I told you about earlier. So we're way behind. We may be detecting it, but we're not treating that for a long period of time. We want to catch them before they fall through that 8-year span. Okay, again, by age range, depression is the smallest in those 3 to 5 year olds, and then of course behavior disorders are the higher category there. As 3 to 5 year olds have more behavior issues, sometimes we look at them as behavior disorders, which may really not be true behavior disorders, just masked as such at age 3 to 5. 6 to 11, depression grows a little bit, anxiety grows a lot, and behavior disorders continue to spike. But 12 to 17 year olds, which are those that we're looking at today, depression still has increased. Anxiety is paramount to everyone else. And then we have the behavior disorders that have dropped off a little bit. As we added more to the anxiety column, those behavior disorders have kind of lowered a little bit. It's more so because they have that increased mental capacity to be able to say, this is how I feel, this is what's going on, and so a more accurate diagnosis has been given. Mental health outcomes, there are so many factors, it's hard to say what the factors of determination would be, but their quality of their home life is a big one. Their relationships with their peers, if they've been exposed to sexual violence, media can be an important one, pressure to conform with their peers. Of course, they're reaching a time when they want a desire for that greater autonomy. All of those things are important, especially when we're looking at their home life, their parenting that they've received to this point, bullying at school, all of those are key factors here. This was just an interesting study that I thought I'd kind of let you know about. It is something that I had not had a lot of experience with, but I find it's very interesting. Adolescents who live in areas that have high levels of artificial light are more likely to have a mood disorder relative to teens who live in areas with low levels of nighttime light. So think, which children are there with these artificial lights at night? Think about where the neighborhoods that they're in when you think about those children. If you're in the school setting or working with really young children, think about those who may live in an area with an increased level of artificial light. Okay, so they looked at 10,123 teens. I don't know who decided that was the size of the study, but that's what they came up with. Between the ages of 13 and 18, there were high levels of artificial light equaled later weeknight bedtimes and shorter weeknight sleep duration. The high levels of artificial light also were found to be more prevalent in areas of social disparities, which is what I was saying. Think about those children that are exposed to that artificial light. This could add, an extra stressor for these teens that are already in a stressful environment socially due to their family situation. So it's important for us to think about this artificial light. It's something that I don't pay a whole lot of attention to how much artificial light am I getting, but I think for our children, it is important when you look at just this age of 13 to 18, the amount of phone time that they have, television time, not to mention outdoor lights that's shining into their windows, perhaps in an apartment complex or a housing facility where these lights are disrupting the quality of their sleep. This is nothing new. Of course, we need to have early intervention. We need to reduce that mean of 8 years of delay. We need to go ahead and intervene as quickly as possible. We can reduce future substance abuse disorder by 1/2 if we have early intervention. Okay, some healthy habits for anxiety. Okay, of course, eat a healthy diet, have 60 minutes of physical activity a day, sleep appropriately, practice mindfulness and relaxation techniques, and we should be good to go. I don't know about anybody else that's out there. I wish I could see your faces right now. How many of you have a healthy diet, get 60 minutes of physical activity a day, sleep as you should, and practice mindfulness and relaxation techniques every day? I don't think there's many of you. If you are, fantastic. I'm so proud of you. Please pat yourself on the back. But for those of us that are not, think about these children. They're also not getting that. I mean, my own children who are in school, they are not able to get 60 minutes of physical activity unless I give it to them when they're at home, because at school they're limited as far as wearing their mask. They may be playing soccer with a mask on or running laps with a mask on. They're not getting 60 minutes of physical activity unless it's done after they get home. So think about how many families are not able to provide just that one piece when we're looking at all of these habits. Okay, so treatment. What are we going to do about this anxiety that we know now is so prevalent? What are we going to do? Of course, cognitive behavioral therapy is one of the key ways to address and treat anxiety. We also have interpersonal therapy, emotional regulation, of course, medications. How many of us hear of children that are medicated, maybe some a little bit more heavily than we would prefer? And then monster side, that's another thing that has come up in my own practice, and we kind of use that as a term of our own, but it is, we have to be creative with ways to treat their anxiety. Monster side was from a child who had a fear of monsters and could not go to sleep. And so his mom got really smart and we decided to put in a bottle. We used some vinyl, put a label on the bottle, and filled it with water and lavender to help him to go to sleep. He would spray his room at night, and he thought it was spray for the monsters. So we have to be creative, whatever this may look like. There is no set in stone, do this, 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 and this, and then you have no anxiety. If that was the case, imagine how the world would be. So we have to be creative and think about what's best for this child at this time, and how can we best get through to them at that moment. Okay, we have a whole list of medications, and I listed here for the age range that's recommended, the diagnosis that it's recommended for, and the medication. So you'll have this to refer back to. I think it's important when you're looking through maybe records and you see a medication and you think, that's kind of odd, I wonder why they're using that. If you know that it's not usually used until 10 years of age or higher, and they're 5 and they're on that, that would kind of key you in to look and see what else is going on. Okay, so SSRIs, of course, are the first choice for anxiety disorders. The response to the SSRIs are typically seen within several weeks for the generalized anxiety disorder, separation, and social phobia. Alternatives to SSRIs, followed by possible consideration of tricyclics, antidepressants, short-term use of benzos, short-term use, and then they may need to initiate a pharmacological treatment of ADHD prior to treating the anxiety. So we have to kind of peel back those layers of the onion, so to speak, and figure out we have to treat this piece before we can treat this. So we may need to truly address that ADHD if they both are existing at the same time. So we're going to manage our symptoms. Remember, we're going to eat that healthy diet, exercise, sleep, have our mindfulness. We're going to use all these things like a kava plant and ginkgo biloba. We have all kinds of things that we're going to use, right? But then you have to try to explain that to an adolescent, which is nearly impossible. So we have our 3 keys to addressing our anxiety. We need to have patience. We need to be curious about what a child is thinking, why they're acting that way, really be almost kind of nosy. And then we need to have an open mind. What happened for this child is going to be different than what happened with this child and what will happen for this one in the future. But I think curiosity or nosiness, whichever one you want to call it, is really an important key that we don't want to lose. So American Academy of child and adolescent psychiatry says for mild to moderate anxiety, CBT is the recommended treatment. Moderate to severe, they want you to combine the medication with the CBT. Okay, I know we have lots of different levels of licensure here. As far as social workers, we are looking at the bio, psycho, and the social components. We are oftentimes the first people that a child will see, whether it's at school, if they're referred to a mental health facility. We are often that first touch point for that child. Of course, like I said, we look at the biopsychosocial components, but it's also important for us to not go it alone. We need to have a team effort approach here, whether it's with the school counselor, perhaps someone in a private practice setting, their primary physician, the family. We need to all be on the same page. We cannot do it alone. Okay, again, some treatment options. Acceptance and commitment therapy. That's a huge one. You hear of ACT, it's huge for anxiety. It's for older children and adolescents. It combines the CBT and the mindfulness. This is something I use very often as my method in practice. Of course, we have CBT alone. We have the exposure and response prevention, which is for children with OCD, social anxiety, specific phobias, panic disorder, generalized anxiety. And then mindfulness-based cognitive therapy is also another one that is used often. So we have lots of screening tools. This is something that I hear a lot of people want to know. How do we know what the level of anxiety is? And is it an issue? Should I do more? What do we need to address? There are lots of screening tools. An easy one is the PHQ. Another one is the SCARED tool. That one's very helpful. And then the SUDS. Those are probably my most frequently used out of the list. I also do like the Spence scale. So there's several here listed depending on your age, the age of your child, that you might want to address. The SCARED tool is one that it's like a bubbled tool that the child can go through if they're older than age 11. They can go through and use it as a self-assessment, and then you score it accordingly, and it's very eye-opening. I like that a lot. Okay, so when we're looking at the anxiety cycle, of course, we have an anticipatory fear as they've become more aware and developed cognitively. They have that anticipatory fear, then they go to avoidance, poor coping skills, increased anxiety, goes back to anticipatory fear, and we continue this cycle until we spiral beyond our control. So if growing up in a secure family environment is a protective factor for adolescent health, growing up in a stable and secure world is probably just as protective. Our world is not very stable and secure right now. So we have to be able to create those environments for them because we cannot rely on the world as it is today. Technology is huge. Sometimes we want to cut back on some of the technology that children are exposed to, but there are a lot of tools that we can use in order to treat these children. Some of these are apps and things that the children can use. Again, this is just a reference list for you to be able to implement in your own practice. We know there's pros and cons. These apps, you can have anybody create an app. If you want to pay somebody to make your own app, you can do that too. So we don't know how accurate they are, how well they are screening, if the information is even helpful and true, accurate information that it may be giving you from those apps. So it's important for you to look at the source and see where that's coming from. Okay, this is another one. For those of you that are multitasking, focus on this. The cost in 2007, which is a long time ago, anxiety disorders cost the United States more than $42 billion per year. And families with a clinically anxious child, they have costs more than 20 times higher than families from the general population. You know, $42 billion, that's outrageous. Now let's look at the school environment. School is totally different than ever before. I don't need to tell you that. It's something that's an ever-changing environment. But the school-based behavioral intervention is so, so important in picking up some of these diagnoses. There's screening for children that and I know as we kind of wrap our head around the COVID times, those of us who are in the school setting, we're going to have to screen these children and make sure of what other factors are there. So again, that list that I gave you is important, but this is cost effective for us to go ahead and do this early on in the school year. There was a study, and I included that just here as a note for you. There were coloring activities that they gave children before test to see if it decreased their anxiety. It did decrease the anxiety for boys and girls with the median age of 10.92 years, so right there at the beginning of adolescence. The unstructured coloring activities were better for boys, whereas the structured coloring activities were better for girls. So again, those of you that are in the school setting, I know I've heard of some teachers who have an activity like this prior to a big test. Maybe the teacher is writing something positive. I know one of my kids had a teacher one year before they would write their spelling test, they would write a positive quote at the top of their spelling test, and she would have something picked out for them. So whether it's coloring activities or something positive to kind of decrease that level of anxiety, and that may be something that is specific to a child that you're working with. You may say, okay, before you take a test, let's remember this, or let's try this. But it's important to notice that unstructured coloring was better for the boys and structured for girls. Okay, how many of you have had a kid that didn't want to get out of the car? I had one this morning. It's actually my very first time I've ever had a kid who didn't want to get out of the car. I've dealt with children who would not get off the bus, willingly got on the bus, but refused to get out. I had my first one this morning who didn't want to get off. Hers was more because she's not pleased with the lunch option for today, but that's irrelevant. She was not looking forward to that. But we have seen children that are refusing to get out of the car, off the bus, go to school, kicking and screaming and don't care. Even if they're adolescents, we think at that age they'll kind of conform to what the social norm is. They won't. When they have true separation anxiety or phobic thoughts in their mind, they're not going to willingly follow suit just because they should. These are true emotions that they cannot handle. Okay, so how do we know if a child in school may have an anxiety disorder? Have you ever seen the child that will erase a hole in the paper to make it perfect? That's the child that may have some anxiety, right? If they're constantly checking over their work, if they are isolating when they're online, so everybody else is interacting and this one is sitting over here kind of staring off into space, it may not be because they can't concentrate, although that's another piece of anxiety. But what do we call that? We don't say anxiety. Mom says, I need you to take some medicine so that you can please pay attention because I don't know what to do with this virtual class stuff. So I'm going to need to go and get you to the doctor and get you on some medicine because you have to pay attention. I cannot teach you, right? But it could be just because they have trouble concentrating. And it could be maybe they're not getting enough sleep. Maybe their diet and their exercise is not sufficient either. But when we're looking at these factors, this is different for those who are doing virtual school. It just kind of presents itself a little bit differently. The same underlying emotions are there. Headaches, stomach aches. Those who are doing virtual, I already heard someone say, I have to take my child to go get their eyes checked because she gets a headache the whole time. You know, every day when she's doing virtual, she gets a headache. Thankfully, they haven't had many virtual days yet because it seems like we always get out of school, most recently for a hurricane or two. But when we have these children that are having headaches, again, it may not be their eyes. Certainly good for us to check that out and check out, of course, everything else, make sure they're healthy. But it could be a combination of things, including their anxiety as they adjust. Okay, so school anxiety, again, it's normal. It's beneficial. It gives us that motivation. We talked about the benefits before. It's not always bad, but it can cause problems as they have heightened attention and they're improving their recall, and all of that is great from their anxiety. At the same time, they may not be concentrating to their best of their ability as the day progresses on. So maybe they start off really strong or they take their test really well, and then the test at the end of the day, they do terribly because they've been anxious for such a period of time that they cannot sustain that throughout the entire day. Okay, so we need to dive into COVID. It's unfortunate that we have to continue to talk about it. It gets old for sure, but we are going to dive into COVID because we have to address how anxiety has been impacted by COVID. Okay, so we have children that are at school. Maybe they're doing virtual school. They're constantly being reminded to use hand sanitizer if they are actually in person. Everyone around them has a mask on. For us, it's a little different having everyone with masks on, but for children, imagine. I mean, I can tell you my youngest started pre-K this year, and she doesn't know who's behind the mask. The first day we did a drive-through drop-off of school supplies, and she was a little nervous, and this teacher came up and started talking to her, and as we drove off, she said, "I like her voice." She has no clue who's behind there. So my other children know because they've seen her before, but she has no idea. So when you think about our adolescents that we're looking at, those children are maybe going to high school for the first time. That's stressful. That's something that we look forward to. Oh, I'm going to be in high school. It's such a big deal. It's really scary when you've never been before. Someone told me this morning, actually, her son was very nervous going to high school. Some of it was going to be virtual, but he was going to have some in-person days. And the teacher sent an email yesterday and said he needs to be in room 503 on whatever day at 9 o'clock in the morning for the safety whatever day. Well, her child is extremely nervous. So she just simply says, you need to be in room 503 at this time. We need to remember that. Well, his anxiety went through the roof. He doesn't know where room 503 is. He just got to school. So the teacher could have maybe thought to send a map along with it. He doesn't know. But to the teacher, she's been there. She knows. So it's not new information. But for a child who has never been able to take a tour of the school, telling them where to go sounds like you're being helpful, but really consider what their position is at that moment. So I like to say that I don't social distance. I physically distance because we cannot isolate these children socially. I'm pretty sure whoever came up with the term social distancing was not a therapist. I'm just going to go out on a limb there. I cannot socially distance. I will physically distance with the best of them. But socially, I think when we continue to use that term, we are becoming numb to the fact that these children need to socialize. Okay, so quarantine, social distancing, whatever you want to call it, we have loneliness, limited distractions, fantastic. They have plenty of time to do virtual. They don't have anything else to do, but they're socially withdrawn. They have a fear of their loved ones getting sick. Perhaps they have a fear of themselves getting sick. They may be worried that if they go to school and they catch the virus, don't even know it, bring it home, maybe grandma's at home and maybe they get sick, or maybe a sibling. Maybe mom just had a baby and they're worried if they bring this home to the child. There's a lot of thoughts going on in their head, but do they understand the biology of things and to be able to say, well, I have a fear that if I touch this, and they don't even understand. I mean, we don't see it. It's hard for them to know, even at 18 years old, for them to say, okay, I'm not going to touch this and then do this because then I might take it home to someone in my family. They don't have that ability. So when we're looking at all of these terms, just think about what's going on in their mind. Okay, so strongly respond to stress of a crisis. Who does? Children and teens, people caring for their loved ones, frontline workers, people at higher risk for severe illness, essential workers in the food industry, those with existing mental health conditions. I mean, have I checked off everybody in your world yet? Those with substance use disorders, people who have changed to their employment, those with disabilities or developmental delays. This goes on and on. But this is everybody that we see every day. Aren't y'all all frontline workers? Aren't you all essential in the world that you're in? Have you stopped truly working? Have you stopped caring for people during this time? Yes, there are people who have had changes to employment or lost their jobs. But for so many of us, and myself included, I haven't seen a tremendous increase in the number of children that I have treated with anxiety. So when we're looking at who is responding to stress of a crisis, Children and teens are right there in that group. And then you look at their families and their parents, they're also in this group. So we have very few that are not touched by that. Anxiety, this fear of illness or death, loss of personal safety, it invokes, of course, feelings of anxiety, right? The new period of insecurity, we're worried about the loved ones. We have this realization of death because we're seeing it everywhere. Sudden separation from our friends. They ended school last year and just poof, it was all of a sudden gone. And they kept thinking, well, we're supposed to go back next week. Oh, we might be going back next month. Oh, we might be going back for the end of the year. So they had this kind of lingering effect. That's huge for children. And we're going to talk a little bit about how that would affect them as they move forward. But first, of course, a survey of 2,111. I like that they come up with some of these numbers. 13 to 25 years old. Again, this is in the UK, where there was the outbreak of COVID. 83% agree that the pandemic worsened their mental health, and 26% were no longer able to access their mental health support. The next study I put in here, I'm not sure, some of you are probably saying I'm not going to pay attention to this, but there's a survey of 8,079 Chinese 12 to 18-year-old children. They were diagnosed with COVID during the outbreak, and they indicated that 43% with symptoms of depression, 37 with anxiety, 31 with depression and anxiety combined, and the female gender was at highest risk. So what do? We know that eye movement desensitization, cognitive behavioral therapy, narrative exposure therapy are all helpful, and those implications are likely beneficial in the face of a pandemic as well. Okay, so what do they tell us about managing anxiety? Identify normal emotional reactions, engage in dialogue and social exchange, maintain appropriate lifestyles and social contacts, avoid substance use, seek information from reliable sources, limit exposure to media. I mean, these are not things that just relate to COVID, right? These are kind of general. Not kind of, they are general. Seek assistance as needed. Okay, when else do you want to seek assistance? When you don't need it? So it's great that we have these guidelines. We have to remember, though, a child is not going to come to you, whether they're 15, 18, 19, whatever, they're not going to come to you and say, excuse me, I'm kind of having a thought that I might want to use a substance, and maybe I need to limit my exposure to my media, and I don't know if I'm having a really good healthy lifestyle, and they're not going to say those things. And they're not going to say, I woke up this morning and thought I might need to seek assistance. Not going to happen that way. So we need to remember that for adolescents, anticipatory anxiety is a real thing as they've become more aware of the world. Some important things that you can use: schedule their time for them to worry. Let them have a few minutes a day, use their worry box. Help them to use the theory of staying present, and I have some of these that are in here for you to use. Breathing and eye exercises are important. I put there cookies and balloons. For a lot of you, you'll know what that is. But telling a child to imagine that they are smelling a plate of the best smelling cookies ever as they inhale, and blowing up a large balloon as they exhale. It's something that you can tell them again when they're about to take a test. Cookies and balloons. Something that they can easily refer to and be able to utilize that. And I have some of these as handouts within the presentation. I have lots that I've already created that I use in my practice. If you would like them, I'm more than willing to share. There's no point in us recreating the wheel. So if you would like any of those, in addition to what's already in the PowerPoint, please let me know after. This is one that I use often in my practice. When I feel anxiety, I can, and it gives them 5 different things that they can do to be able to distract themselves. Okay, so social media is an important factor, but media in general. How are we going to protect children? We want to shelter them as much as possible, but how do we address media? We need to make sure, of course, that we're seeking reliable information, and children are on maybe TikTok or Snapchat, and they're getting information that may not always be reliable. Okay.
What has been your experience about how parents are contributing to these issues in their children right now, socially isolating them choosing homeschool or virtual learning when child is learning or accommodation needs, expecting child to be able to navigate virtual schooling without help, like a virtual babysitter, etc.
I like the virtual babysitter.
You might not be able to hear.
Okay, so she's just reading the question that was just in the chat, asking how parents, to sum it up a little bit, but how parents are contributing to the anxiety of their children during this time, whether it's a virtual babysitter for school, and expecting them to be able to set up in front of a computer, push start, and I'm going to maybe watch the news or or go do housework or whatever it is, and expect them to function on their own, especially for those who may have some challenge. And I definitely think that the parent's view skews the child's level of anxiety. I woke up this morning, I always spend a few minutes wasting my time on social media as I drink my coffee. So I sit there this morning, the first thing I saw was a mom saying, what do you think about this, the way that school is going? Is it a political thing? You know, when are we going to be done with COVID? And she's being very negative in regards to how school is going to go. Her child is picking up on that. No, her child may not be watching it on Facebook, but they're seeing that. And that mentality of how she views school, certainly if you have to go and do virtual school with your child or get a virtual babysitter, that attitude is going to come out for the child. I also think their level of anxiety, while for that there's negativity that goes along with it, in regards to their anxiety, you're not setting them up in a setting where they can have everything they need, have all the tools at hand, know that mom's there if I need to ask a question, know that my virtual babysitter knows how to work this computer program, know that, you know, what if I can't hear, what am I going to do? If they don't have that, then their anxiety is going to increase. And we need to feel comforted. And so I think it's really important for parents to, of course, and it sounds so silly, but they need to watch what they're saying around their children and the attitude that they're giving off, even when the words are not coming out. They have to have positive support. They have to have positivity that's expressed to them, regardless of whether you agree with it or you think it's a good idea, you like it or you don't like it. If we put it to them in a negative manner, we're going to continue to increase their anxiety. And I think that parents focusing on that negativity is really doing a disservice to their children in regards to their anxiety, especially when we look at the virtual babysitter. I like that virtual babysitter title. Something else I just put in as a reminder for those adolescents, they have their own phones, they're using their cell phones frequently. Make sure they have these numbers there. So if they don't feel like, in that case, for a parent who is maybe a little bit more removed or a little bit more negative about the current states that we're in, let them put these numbers in their phones so they have someone to support them if they should need it. So if they don't feel like their virtual babysitter is there for them, if they are extremely anxious or perhaps their depression is out of control or whatever their symptoms may be, letting them know that they have a resource there is important. So it's easy for them to have it in their phones, whether it's a friend, family member, or some other virtual contact with someone. Okay, so pros and cons, and I want to make sure that we're good. Okay, I don't want to go over time. Here's some pros and cons, of course. These are things that we've looked at before, but in regards to isolation, kind of distancing ourselves, we have social media is readily available, teletherapy, telepsychiatry, all of those things are there, which is wonderful. We're free of bullies when we're at home. But we also have to remember that we don't have the ability to isolate. We do have an increased risk for violence, substance use, not only for the adolescents, but in the home as well. Okay, so COVID rebound. Adolescents are going to have a variety, a whole spectrum of how they feel about coming out of isolation. Some of them will have mixed emotions, maybe grief, fear, worry, health concerns. They're worried about their family member, sadness, anxiety, frustration, anger, guilt, all of these things. Another key thing is that sudden termination of school that we had last year, that lingered for a while and then kindly came, to an abrupt stop and, okay, now we're really not going back to school. That sudden termination may lead to reluctance for them to attach in future school years. Because what if I get too settled in my routine? Or what if I like this? And what if I have friends here? And then all of a sudden we don't have school anymore. So they may not allow themselves to attach or to become invested in those relationships, whether it be with a teacher, their peers, or maybe not invested academically. I think that's a huge one. I've already seen it in my own house and with some of my clients as well. We started school, we went for a little while, it was very different. The new kind of wears off and then we're out of school for storms and then we go back. And so it's hard for them to say, I'm truly going to have a test in a week, or I'm truly going to have to know this by the end of the semester, because they may not have school, or they may be at home by then, or they may be sick by then. So it's hard for them to attach and be invested in those relationships. Okay, this is another one that I think is important. It's something you can teach children, whether you're in a school setting, again, in a private practice setting, whatever it may be. Implementation of this in your practice, I think, is very helpful for children to have this in their mind. So it's a good visual for them to know the term fear. Of course, they're feeling frightened. They expect bad things to happen. They have attitudes and actions that can help them, and they know the results and the rewards. And you can go through this for each individual child and help them to know what their fear is so that they can use that and kind of when they're away from a handout or a worksheet. Something else that's important is for them to have those little things that they tell themselves in their head when they sit down to take a test or whatever it may be. Helping them to figure out what that mantra may be is something that can be very helpful. So asking them, okay, when you're in this moment, let's pretend that we're looking at test anxiety. If we're looking at that, what are we going to say to ourselves to be able to kind of get ourselves together and push through and take the test as best as we can? So maybe they'll say, I will do this, I'll never do that, I won't do this, I am this, or I can do this. Help them figure out whatever their mantra is and let them use that and get it to be something that's ingrained in them. So I'll often do this, let them write it on there, take it home, tell them to put it on the mirror, and use this and look at it every morning as they brush their teeth and every night before they go to bed while they're brushing their teeth, so that they have this in their head and it is readily available. So their mantra could be anything. I'll tell you, my own child has done this. She has had anxiety in the past, and one of her things that she came up with as we kind of went through the same exercise as she did on her own was, I do not have to be perfect, but I will do my best. That kind of is a theme that she has, and that's something that I don't have to do a perfect job, I don't have to do 100%, I'm going to do my best. And I think that's really important for her. And it's something that she does tell herself, but it is something when I know she has a big test or something stressful, whether she does dance and she's going for an audition or whatever it may be, I may remind her of that. My son has a different mantra that he uses, and it'll be interesting to see what my youngest comes up with for hers. So again, children are likely to live up to what you believe of them. I just like that. I think it's important, thank you, for us to remember that our expectations of our children often come to be. So kind of going back to the question that we talked about earlier, parents sometimes, I know it's shocking, parents sometimes contribute to the problem. We did talk a little bit earlier also that there are genetic factors to a lot of anxiety disorders. And I use the word disorders, but just anxiety in general. We don't all have to have an anxiety disorder to struggle to function with our anxiety at some given moment. So when we're looking at that though, and there are those genetic components, whether maybe mom has had some anxiety in the past, maybe dad has a phobia of something, maybe grandma had panic attacks, whatever it may be. And a lot of times with that avoiding going to school, you'll see as you talk to your clients, you'll hear people say, oh yeah, my aunt used to do that, or my grandmother said that, my mom used to do that, or whatever. So you'll hear that there is a theme there. So a lot of times parents are, we don't want to say to blame, because clearly as parents, we're not to blame, but right? So we don't want to say that they're to blame, but those factors are there. So if that's something that's underlying in the family, then they expect that it will be there for this child also. So when we're expecting it, we believe it of them, then they're going to live up to it. It's that self-fulfilling prophecy piece that if we say, you are the blank child, whatever it is, oftentimes that's what they're going to be. You're my anxious child. I've heard that before, not even in my practice, but just with other parents. I've heard, oh, well, you know, she has anxiety. Well, yeah, but she probably doesn't have an anxiety disorder, but if you keep telling her that, she may go ahead and do it because that's what you believe of her. So she is okay with saying, I'm the anxious one, and I've heard that this one that's in my head that I can hear so vividly saying it, the child will say, oh yeah, but you know, Miss Donna, I have anxiety. Yeah, but we all do. Everybody has anxiety. It is not always a bad thing. But when mom keeps saying that, oh yeah, she has anxiety just like so-and-so, or she, you know, then yes, she's going to continue to do that. It's the same for so many things. How many times have you heard the people who say, oh yeah, that's going to be my child that's going to give me a problem? Well, then we're going to see problems. First of all, we're looking for the problem. Second of all, we've created an avenue for them to have that. Okay.
I've seen many of my anxious teens use their friends as their major coping skill. The isolation has only increased their anxiety, and social media connection has either not been enough or has caused more hurt than help. Can you talk about the lack of socialization leading to an anxiety increase?
Yes. So this is a question again that was in the chat as far as a lack of socialization and how it affects their anxiety. Again, I told you I am not going to socially distance. I will physically distance. It's very important, and children cannot rely on social media alone. It's huge. It's great. I mean, 20 years ago, was your child certainly not on TikTok, but was your child communicating over the internet? No, they were maybe, I don't know, playing, what was it, Oregon Trail and waiting on the modem to dial up. So they were not interacting socially in any way. So it's huge that we have that. Had we had this quarantine period years ago, we would have a very different outcome. But it is not a replacement for social interaction. I will say, however, I firmly believe that children are so resilient. If we don't make a big deal out of it, a lot of times it's not a big deal. So when our parents of our clients are focusing on, oh yeah, but he doesn't even get to do this. Oh yeah, well, she doesn't get to have a birthday party. And oh, we didn't get to go on vacation, and we can't do that, and we can't do this. Of course, they're going to suffer more. We all have that need to socialize. So you'll hear of people having that bubble of trust. I've heard of some other of my clients and other parents that have like a bubble of trust. So we know that this family is isolating to the same degree that we are, and we're going to trust that they are safe for us to go around. So maybe you have one friend that your child would interact with and be able to fulfill that social need that they have. Having them, there's lots of programs online also that are helpful. I would check them out thoroughly before you recommend them to a client, just because they're online. But there's a lot out there socially. There's different forums that are set up. There's even some programs that are kind of structured to be able to address the socialization during this time. So you can find a lot of free materials there online without them having to rely on their friends, because we know that people say things online and act like there's not a real person on the other end. They say whatever comes to mind, as children do, but then they type it out, it comes out to you, and you hear something very harsh, and that can be detrimental to the child, especially with their self-esteem and their anxiety. So maybe looking at some other avenues as opposed to just relying on friends on social media. So I think that's a huge one. I think we're just about out of time for today. So again, I appreciate all of you taking time and allowing me to kind of share a little bit about anxiety. I do want to encourage you to email me if you have questions, or if you would like some of the information that I talked about in regards to those handouts and things that I use in my own practice. I'm more than happy to share those with you. Also, those of you who are in a school setting, if you have struggles or concerns about those children, I'd be happy to talk to you about some ways that you could address those as school continues to evolve in whatever manner and time frame that it will. So I'll be happy to talk to those of you that are in the school setting also. If you want to send me an email, I'll be happy to do that. Are we? Okay, I think we're good. How am I? Yes, right? Are we right on time?
Turn off your mic and I'll say thank you.
Okay. All right. Thank you all again for listening today. I appreciate your attention.
Again, we'd like to thank Donna Wimberly coming to the Donna Wimberly State. That was a great typo. It was even better that I read it out loud. That was good.
That's right. I hope y'all enjoyed it and being in my state.
We appreciate you very much and appreciate the knowledge that you shared with us. You're going to go to a 15-minute break, and then you can join us for our last session for the day. Thank you very much, everyone, for attending this afternoon.